Okay, good evening, everyone. Welcome to the Southeast Asian Thoracic Society, or SEATS. And I hope everyone's taken their seats. I am Dr. Edmund Villaroman. I am a thoracic surgeon from the Philippines. I'll be moderating this webinar. So this is our second webinar in a series of webinars brought to you by SEATS in partnership with Medtronic. So in this webinar, we'll be going back to the basics, the basic fundamentals of anatomy and physiology, how it applies to our practice as thoracic surgeons and respiratory specialists. We have two distinguished gentlemen to discuss this. But before we start, let me just go through some ground rules for tonight's webinar. Oh, sorry. So the video and audio functions of the participants are disabled, but you can post questions through the chat function. Just open the chat function. I'll be reading through the questions, and I will be asking the questions at the end of the two lectures. Okay, so let me introduce our first distinguished speaker, Dr. Padungkiat Tangpiroontham. He graduated medical school in Siriraj Hospital, Mahidol University in Bangkok in 2007. And he completed residency in cardiovascular and thoracic surgery in the same institution in 2015. Then he went into clinical fellowship in thoracic and thoracic surgery at Harvard Medical School, Brigham and Women's Hospital in Boston, Massachusetts. Completed it in 2017. He is a practicing minimally invasive thoracic surgeon at Bangkok Hospital, Bangkok, Thailand, and a faculty consultant, cardiovascular thoracic surgery, Siriraj Hospital, Mahidol University. So may I call on our first speaker, Dr. Padungkiat.
Thank you very much, Edmund, for a very warm introduction. So before we start, I like the audience to give us some response on the experience that you have in the thoracic surgery, so we know that our aim is. You can just go to any of your iPhone, of your Android, to the menti.com and put the code 899930, and there will be an answer coming up, so you can just click it and please. I'll wait about a couple of minutes and then I'll start my presentation. Okay, that's great. How do you like it, Naveed?
Yeah, the trainees are much quicker at figuring out how to do it. I think that's why they're taking the lead.
This is a pretty neat tool, yeah, for webinars.
I learned it from Pun. So we have the attendee around 80 to 90. Let me see. Okay. So it's now 36 response. Well, it should probably enough. So most, more than half of the attendees are trainee, which is good. And there's a lot of attending physician with a lot of experience coming too. All right, let me start. So today I'm going to share, I would like to say, share my experience on the pulmonary and bronchial anatomy and development And I know that seems like there's no medical student. So the trainee, I believe, have some quite a knowledge on the anatomy and embryology already. So I'll make it quick, and I'll make it directed to the surgical relevant too. Okay. All right. So Henry Grace once said, "The surgical anatomy is." To the student of medical and surgery, it's the most essential branch of anatomical science. And so you have to have a knowledge of the most important regions and consisting in the application of anatomy, generally to the practice of surgery. Okay, so it's very important. It's not a preclinical anatomy. The surgical anatomy is different, and I'll go through this in my slides. But I'm sorry, I need to start out with the embryology. You know that it's not a very exciting topic. So, but it's very important too. Okay, so I'll start with the airway. Our airway, the laryngotracheal tube. It's arising from the splanchnic mesoderm, and it is bifurcated into tracheal buds and continuing bifurcation, and give us a bronchus. And at the end of the 8 weeks of the fetus, you have 3 lobes already, and also the bronchial buds. And this is pretty much the same slides but shows that the correlation of the aorta and the SBC, it's also arising in the mesoderm, very close to the esophagus and the trachea. And as the day goes by, the airway continuously grow and be associated with the blood vessel and creating the blood alveoli barrier. Okay, and the most important thing that you need to know from the embryology of the airway is that by 36 weeks, the alveola it's completed, and so it is the point that the gynecologist think that it's okay for the fetus to deliver. But the alveola continue to grow up to 2 years. So even though we need to do a lung resection, and if we do it before 2 years, the lung can grow back on and continue to fill the space. Okay, and even after 2 years, the cell continue to proliferate, and the lung can grow and expand more up to 18 years old. Okay, and there's the phase of the airway, starting from the pseudoglandular phase and go to the canicular phase, and eventually form the blood-air barrier with the type 1 and type 2 alveolar cell. Okay, so next up to the pulmonary artery. The pulmonary artery arising there's 2 parts. The main PA is arising from the truncus arteriosus, and the LPA, RPA, and the ductus arteriosus arising from the 6th pharyngeal arch artery. And but the pulmonary vein is different. There's no arch of artery or anything else like that. It's only the splanchnic mesoderm. It's forming a splanchnic plexus, and the plexus itself form a pulmonary vein, and vein get absorbed to the left atrium. So there can be a condition called a TAPVR, the total, or PAPVR though. The total or partial anomalous pulmonary venous return, because there's no major venous return to the heart. It's just that it just get the pulmonary vein get absorbed. If it get absorbed differently, it can go to the coronary sinus, portal vein, or the SVC. Okay, this is another picture that how the pulmonary vein get absorbed into the left atrium. All right, I promised myself to finish the embryology in less than 5 minutes because I know that the more exciting part is the anatomy, right? So everyone now has an app, an iPhone, an iPad, and there's a lot of apps that's very fancy. It can show you the 3-dimension of the PA, PV, and the airway and the heart, and they can remove the part of the pulmonary vein, pulmonary artery, and show us the airway itself. But it actually, for the surgical standpoint, it doesn't really help us doing surgery much. So there's a surgical anatomy has a systemic anatomy. You go through by the system, the airway, PA, and PV. But the more importantly, you have to know the surgical view anatomy. Now it's different from the past, because in the past when you do a thoracotomy, you look right down into the chest. You can flip lung front to the front and to the back easily. But when you do a VATS or robotic, uniportal or multiportal, the view is so much different from the thoracotomy. Okay. But I'll start off with the systemic anatomy first. So I think everyone here knows that lung has 18 segments depending on the books. Some has 19. The right lung has 3 lobes, the left lung has 2 lobes, the right lobe has 3 segments, middle lobe 2 segments, the lower lobe 5 segments. And the left side, upper, has 4 segments, and lower had 5 to 4 segments depending on the books. The airway, and it just follow the lobe and the segment. It's in the trachea zone. It has very close association with esophagus and the recurrent laryngeal nerve. When going down into the chest, right at the manubrium location, which is the T4. It's a carina level. It's just a number that you have to know. And you branch into the right main bronchus, left main bronchus, and go on to the segmental airway. That you need to know. But more importantly, if you are a thoracic surgeon, you have to be familiar with the bronchoscopic view of the airway. It's very hard to teach you right now, but as you know, there's with the apps and everything, you can go to this, for example, the Broncho Guide, and you can go slowly into each of the airway, and you can get the feel of the airway. Okay, for the training. So pulmonary artery, there's the right side and the left side. The right side has a branch of the superior trunk, and then go to the apical, anterior, and the posterior, apical and anterior. For the posterior ascending artery, mostly it comes off in the different branch, right opposite to the middle lobe, okay? And then it branches into the basilar artery. So if you want to do the basilar segment, you can just go just below to the middle lobe and the superior segment and cut everything distal to that. On the left side, it goes to give you the trunk, the anterior, posterior, and apical trunk, and the posterior ascending artery. It can come off separately. And then the lingual artery comes opposite to the superior segmental artery. Okay, so this is the anatomy that it shows in the picture, but when you do a surgery, it's completely different how you have to perceive that. Okay, but So this is that the anatomical variation can be almost 50%. You have the one truncus arteria, one posterior ascending artery, and one fourth. You have two posterior ascending artery. But most importantly, the anatomical variation you have to bear in mind is the posterior ascending artery arising from the superior segmental artery. Okay, so if you do a right lower lobectomy right here on the circle, you have to make sure that the posterior you see the posterior ascending artery before you cut that. Otherwise, you have to end up doing the posterior segmentectomy of the right lower lobe. And another anatomical variation is that the right middle lobe comes off very proximally, okay, and on the 1% of this. So in that case, if you do a right upper lobectomy, you have to make sure that, and especially if you do a fistulized technique, that you cut everything from the front, you cut the truncus anterior, and you want to cut the posterior ascending artery. You see a trunk, but if you don't see the right middle lobe artery yet, you cut it and you remove the right middle lobe artery too. So then you have to do the bilobectomy. All right, next up, it's on the right lower lobe. It's the most of the time you have the one common basal artery, and the superior segmental artery and middle lobe artery comes up oppositely. Now it's very easy to do, but same as last slide. If the upper lobe arising from the middle lobe, that's the things that you need to bear in mind that can happen. And for the left lower lobe, it's the same thing. The lingual line coming off from the basilar artery. Okay, so or posterior ascending artery coming off from the superior segmental artery. It happens rarely, but just to bear in mind. Okay. All right, next is a bronchial artery. It supplies both bronchi and esophagus. Normally you can injure it during the lymph node dissection, but it's not a very big deal. It's mostly you have one on the left, two on the right, or sometimes you have two on the left, two on the right. It has some anatomical variation. So this is one of the things that you may see in your career, that the systemic artery comes off and supplies the lobe itself. It's called pulmonary sequestration. And it can come off from the thoracic aorta, about 70%, and the rest comes off from the abdominal aorta, and few percent comes from both of them. It's the infralobar and extralobar. A patient can present with a recurrent hemoptysis and infection. So this is the case that I did a couple of years ago. This is a CTA, and you can see you can see my pointer, right? I believe you can. Okay, all right. This is the artery comes off from the descending thoracic aorta and developing the aneurysmal formation afterwards. And so you can, this is how the lung looks like for the pulmonary sequestration. The lung will be firm, even though it's collapsed, and irregular surface, and you have to find a feeding artery, and you just cut it, and I did the vest resection on the bad lung. Okay, so next to the pulmonary vein, the right side has a superior pulmonary vein that has supplied both upper lobe and the middle lobe. Okay, it's different. There's a right upper pulmonary vein and right superior pulmonary vein. So for the trainee, you have to know that how it's different. So right superior has the tributary of the upper lobe and the middle lobe. The rest is just very straightforward. But this is what you have to bear in mind, very important. I've seen some case that had to end up with the pneumonectomy. So what this is condition called anomalous unilateral single pulmonary vein. So if you, so as I explained before, the pulmonary vein get absorbed into the left atrium. Normally you have 4 holes in the left atrium, right? But sometimes more on the right side and the left side, 0.5%, that pulmonary vein does not get absorbed totally. So you can see this is how I was about to do the left lower lobectomy. When I lift up the lung, and you can see there's a branch supplying the left upper lobe too. All right, so if I encircle right here, that's a pneumonectomy. So I just need to cut a little bit more distally. And so, okay. And the other conditions that you have to bear in mind is the right middle low pulmonary vein draining into the right lower pulmonary vein. Same thing with the lingula. Lingula can drain into left lower pulmonary vein too. So when you want to do a right or left lobectomy, please make sure that middle lobe is not drained into it. It's 10 seconds review before the OR, but it can save you and your patient's problem. All right, now next up, with surgical view anatomy. Okay, so you as a surgeon need to know the relationship of the bronchus, PA, and PV when you do the section around the hilar or in the fissure. So when you do a VATS or robotics, the view is different, especially if you're doing portal, because you're going to view from front to back only, okay? And you need to be familiar with the fissure last technique to minimize the post-operative air leak. So this is the left upper pulmonary vein, okay? So when you see this and you want to do lobectomy, next is you're going to dissect and mobilize and open the anterior mediastinal pleura, right? So I did, and I mobilized the anterior to that already. I was about to encircle it, put the right angle back to it. So I want the audience to think about 30 seconds. So what's the structure behind that? Okay, what's the structure behind the right angle here, the lingular vein, and what is the structure behind the apical vein? I believe the experienced surgeon knows that already, automatically, but the training for you is very, very important. Okay. All right, so next is the answer. So this is what's behind it, okay? What's behind the lingual pulmonary vein from this view is the left upper lobe bronchus. And what behind the apical vein? It's a PA, it's a truncus anterior, okay? So that's why I almost always, when I dissect around this, I put a silk here. Just sometimes around the whole pulmonary vein, but most of the time only with the apical vein to make sure that I lift it up, because right down here is a bronchus. It normally just put a right angle in there with the less caution to the right here. But right here, I want to make sure that I get as close as possible to the pulmonary vein so it will not injure the artery behind. Okay. So next, now is the right upper lobe. So you see, this is the right upper pulmonary vein, phrenic nerve, the prevascular lymph node. Okay, so It's you can identify the PAV easily, right? But I want you to think what's behind this right upper pulmonary vein. 30 seconds. Because you need to get around it, right? All right, so here we go. So right behind the right upper pulmonary vein is the PA. The ongoing PA, you can have the posterior ascending PA, and it is very vital structure. So you have to be very, very careful to get around this structure. And more importantly, if you as an attending, you experience, you know that there's a lymph node here, there's a bronchus behind the PA, and there's a azygous vein up here too. So when I see the experienced surgeon operating, they're not just trying to dissect the pulmonary vein, and they opened the whole anterior mediastinal pleura right here up to the azygous vein, back to the posterior. Okay, so because you know you have to dissect around this structure anyway, it saves your time a lot when you do that. Okay, and this is what you see when you mobilize the anterior mediastinal pleura already. And now it's middle lobe. So this is the right middle lobe PA, and this is the upper lobe PA, PV. I'm sorry. So, all right. So behind the right middle lobe pulmonary vein, it's a bronchus. It's not a PA. So you hear that when you ask your attending as a trainee, at which lobe is the easiest, most of them will tell you it's the right middle lobe. Because if you start from the front, you get around a PV, right behind that is a pulmonary vein, is a bronchus. So it's not very the most dangerous area to be. Okay, but right behind the bronchus is just the PA, as shown in this picture. So if you when you go through the fissure, if you're lucky, the fissure is totally complete like this. It's very easy. Either you want to do a right lower lobectomy or right middle lobectomy, you just go and mobilize the middle lobe up a little bit. You see the branch of the PA, and you always see the lymph node here, and the bronchus is right below the pulmonary artery. It's shown in this picture. Okay, but unfortunately, sometimes you go in and you see a thick fissure, and you know if you dive in, the chance of LE, the chance of patient length of stay will increase is high. So you want to do a fistulized technique. So you flip the lung up, right? You see the pulmonary vein. I'll give you 30 seconds to think what's behind the pulmonary vein, if you want to cut the fissure as the last thing to do. Okay, so I dissect the inferior pulmonary ligament already, exposing the pulmonary vein, and this is the inferior pulmonary ligament lymph node, and there's some esophageal lymph node here. So, and I mobilize it a little bit more from here, and you see this is a pulmonary vein here, right? So what's actually behind that? This case, I tried to go into fissure a little bit too, but when I cut right up to here, you can see that this just still have this kind of thick the lung tissue, and if you dive in, there's going to be a long post-operative leak. Okay, so this is a pulmonary vein here, right? Behind it is the bronchus to the left lower lobe, and above that you have the base of the PA, and behind it you have the posterior superior segmental PA. So if you want to do a fistula last technique, so you start from pulmonary vein, you cut it here, and then you expose the bronchus right here, and you cut the bronchus, you then expose the PA, and after you cut the PA, you can cut the lobe out. Okay, so when visualize from the anterior, this is my last slide, from anterior. So the structure posterior to the right upper lobe vein is the main right pulmonary artery and the posterior ascending artery. And posterior to right middle lobe pulmonary vein is the bronchus intermedius and right middle lobe bronchus. Posterior to the lingular vein is the left upper lobe bronchus, but posterior to the trisegmental left upper lobe PV is the main left upper lobe PA, and also the trisegmental PA. And if you do a visualize from the inferior left, posterior to the left lower lobe PV is the bronchus and followed by the PA. And it's same thing on the right side. And from the fissure, it's mainly as a PA above and the bronchus below. So if you have a complete fissure, very easy to do a lobectomy. So the conclusions, the airway is mostly straightforward. There's not much of the anatomical variation, but you need to be familiar with the bronchoscopic view. On the right, PA, you have to be familiar with the right middle lobe, posterior ascending, and superior segmental PV variation. It stays close by, and it can arising from each other very easily. And from the left, PA, the lingular and the basilar PA can come out from each other, and the posterior ascending artery and superior segmental artery as the variation. So, and be familiar with the surgical view anatomy for safe dissection and circling around important structure. Thank you.
Thank you very much, Dr. Padungkiat, for that very interesting lecture. I like the twist of the surgical correlation with anatomy. Okay, let's now proceed to our next distinguished lecturer, Dr. Naveed Alam. Mr. Alam has been a consultant in the consultant thoracic surgeon for 15 years at St. Vincent's Hospital in Melbourne. He trained in thoracic surgery in Canada with fellowships at the National Cancer Institute of Canada and Memorial Sloan Kettering Cancer Center in New York. His interests are minimally invasive thoracic surgery, airway surgery, and thoracic oncology, as well as teaching. As a board member of the ATEP, the Asian Thoracoscopic Educational Platform, he participates and organizes training sessions for students, for registrars, qualified surgeons locally, nationally, and internationally. So again, Dr. Naveed to talk on the pulmonary physiology and assessment. Dr. Naveed.
Thank you very much. See if I can get this organized. All right, am I sharing my my PowerPoint?
Yes, yes, can see it.
Okay, great. All right, first of all, thank you very much to CIATS as well as to Dr. Soon and Dr. Edmund for inviting me to present today. I also like to congratulate Hong on that presentation. That was very interesting. As we're pitching to primarily, it looks like 50% trainees and 50% attending or consultant surgeons, I'll keep this fairly surgically focused and try and make this relevant to day-to-day practice. So we'll just launch in, and hopefully it won't be, it'll be pretty understandable. So just an outline of what I plan to talk about. I'll discuss a little bit about the historical perspective of pulmonary physiology and assessment as in the perspective of surgery. We'll do a very quick review of important things in pulmonary physiology. And then we'll look at some preoperative testing and the sort of traditional cutoffs and guidelines that we, all of us older surgeons learned, and maybe some of our trainees are learning now. And then we'll look at what there is in modern practice that may influence us to modify those guidelines or think about how we might do things differently, and certain things like whether you're doing an operation VATS versus open, or patient factors might come into play in terms of how you can get a patient who's sort of borderline physiologically through an operation, because we're surgeons, we like to operate in well, so we know that it's the best treatment by and large if you can handle it. And then the last thing I'll touch on is just how low can you go in terms of these values of pulmonary physiology, in terms of operating, and how low should you go? And I'll just briefly talk on quality of life measures and some of the things that patients actually think are more important to them. So just to put this all into a bit of historical context, the first sort of recognition that pulmonary complications were the most common cause of morbidity and mortality in the early postoperative period was presented in a paper in 1932. And that was basically what seems quite intuitive to us, but at this time it became at least shown for the first time in the literature. And a statistical study was done, and basically it was just anecdotal evidence, but that was good enough to get the ball rolling. And then really in the 1950s, we had the advent of spirometry. And in there, we had a number of seminal papers by Dr. Miller, a very famous cardiothoracic anesthetist, who talked about the convenient method for evaluating pulmonary ventilator function with a single breath test. And also the role of pulmonary insufficiency in mortality following surgery for TB. So keeping in mind that in the 50s, up until that point, most thoracic surgery, a lot of thoracic surgery would have been TB related. And similarly, this sort of beginning of our understanding of pulmonary physiology started to get us to look at whom we could operate on and whom we shouldn't be operating on. But this clearly required quite a bit of refinement, and it wasn't really, and we looked at this in a paper at JTCVS in 1986. They looked at what are the random reasons that people die after a thoracotomy for lung cancer versus the predictable ones. And they looked at the time, the most commonly used measures of a preoperative risk assessment, which was primarily related to spirometry and history taking. And they were only able to predict 12% of the mortality, whereas 88% of mortality was still random or unknown. And it was soon after that, in the late 80s, when we started to add DLCO into the mix. And we noted that the diffusion capacity actually predicts morbidity and mortality very well after pulmonary resection. And this is sort of where we're at, and there hasn't been necessarily a dramatic change since then. So, and I say that by saying that if we look at the current American College of Chest Physician guidelines or the British Thoracic Surgery guidelines, we see here the first test when you're trying to decide whether or not to operate on someone is to perform spirometry, look at their FEV1, and we kind of have guidelines of what kind of operation we can do for someone based on their FEV1. And similarly, we might look at their DLCO. But it's important to understand where these guidelines come from and to be able to then apply them to modern thoracic surgery practice. So now I'll just take a quick step back before we go to that, and I'll just talk a little bit very quickly about pulmonary physiology. So especially as in terms of how it relates to thoracic surgery practice and the measurements that we're taking for all of our patients. So we all know that depending on the practice setting that you're in, you might be doing your own pulmonary assessments, preoperative assessments, or there may be a respiratory physician or a pulmonologist involved, or other physicians, anesthesiologists, anesthetists involved. But one thing that everyone's going to be looking at is the FEV1, which is the forced expiratory vital capacity, forced expiratory ventilation in 1 second. So we know that if we look at this flow volume loop, and if we look at the left side, and I'll just use my arrow here, but we're starting at time 0, and what we're doing is we're starting with the full lungs, big breath in, and then you exhale as quickly as you can. And the amount of lung volume that you expire after the first second is your forced expiratory ventilation in 1 second. And then you'll go down to your FVC at the end of expiration. You have a long breath out, and then you take your breath in and you get your inspiration. And then this also can be extrapolated onto another flow volume curve, and you can get a sense of where the FEV1 is based on that curve and drawing the asymptotes or the lines to where it goes. But really what this is a measure of is a combined measurement of the way your chest wall mechanics and your musculature are working, as well as the elasticity of your lungs and the compliance of your airways to be able to get rid of air in 1 second. So it's really a big picture, global measure of ventilation. And really in pulmonary physiology, as we know it, and as we try, we're surgeons, we want to keep things simple. There's really two things that matter. One is ventilation, and the other is oxygenation or perfusion. And so we have one measure that we are really reliant upon when we're trying to decide if someone can handle an operation, and that's how good are they at ventilating their lungs. So that's often, how good are you at basically getting rid of carbon dioxide is another way to think of that. And then the other thing we're interested in is oxygenation or perfusion. And the test that we use here to look at that is the DLCO, which is the diffusion capacity of the lung to carbon monoxide. And really what this test does, again, it's in a breath hold in a pulmonary function lab, and you inhale a combination of an inert gas, usually something like helium, with a bit of air and carbon monoxide. And through some complex mathematics, we know that carbon monoxide gets picked up by hemoglobin, even preferentially over oxygen, whereas the inert gases help us measure the ventilation and the volumes that are being involved. And then some math is done. And basically what you get is an idea of how good your alveoli are at providing a surface area and a membrane to exchange oxygen in the alveoli into the bloodstream. And we can see that demonstrated here in our little schema. Basically, you've got deoxygenated blood coming in from the pulmonary arterial side. It's in contact with the surface area of the lung, the alveolar surface area. Oxygen goes in, carbon dioxide comes out, and we have that oxygenated blood. So this is a function of how good the lung surface is at transmitting oxygen and carbon dioxide across that blood-air barrier. And this is, as I say, in some ways, ventilation and oxygenation or perfusion are almost like perpendicular vectors. They're often involved or compromised by the same pathologies, but in a lot of ways they're independent. And you can have someone that's got great ventilation but very poor perfusion, or the other way around, or bad in both. So these are that's why it's quite important to be able to measure not just FEV1 but also DLCO and get a better idea. So just with that in mind, if we go back to what the current guidelines are, we see things here. And where do these guidelines come from? Well, we say current guidelines, but this is actually just based on data from 3 large case series that were published in the 1970s, well over 2,000 patients. So quite a robust data set in terms of volume of patients and to which to determine who would do well with thoracic surgery. But at the same time, quite old data where we know that modern thoracic surgery practice has changed quite dramatically since that time. So there might be some more sophisticated models that are out now. And so here's just one example. And I'm not going to spend too much time on these flow charts because, there are things that we all it's quite easy to access, but basically you want to have an idea of if they've got a cardiac history, then you want to probably assess their heart as well. But more from a pulmonary standpoint, you want to know what's their FEV1, what's their DLCO, and if they make certain cutoffs, and we know that sort of, big picture ones, if you're going to leave someone with, traditionally what we're talking, you're going to leave someone with more than 40% of their postoperative predictive FEV1 or DLCO, then you probably can go ahead with surgery. If you're going to leave them with less than 30, then you probably can't go ahead with surgery, and in between is where you might want to do some other tests. That's just a quick sort of nutshell assessment. But let's look into it in a little more interesting fashion for modern thoracic surgery, and especially when you're having a discussion with your respiratory physician or your pulmonology or your anesthesia colleagues afterwards, and you say, look, I think this patient can handle an operation. They say, oh, well, no, by the numbers, they can't. And that's where it's important to be able to back up your anecdotal or your clinical acumen with a bit of data, perhaps. And that's maybe where it can help you out. So are these old tests quite meaningful? Well, there's a group that looked at something which is not just the postoperative predictive FEV1, but what's probably more important in what's called the worst case FEV1. And so what you're seeing in this graph is In the first bar here, that's the preoperative FEV1 of these group of 125 patients. In the next one, you're seeing what the postoperative predictive FEV1 was. And what they did was they did daily spirometry on these patients. So actually now what you're seeing is FEV1 on day 1, 2, 3, 4, 5, 6. So you get a better idea of what's going on. And so in this group, the FEV1 pre-op was 85%. The post-operative predicted FEV1 was 70%. So they were, doing a lobectomy. They were going to lose a bit of lung function. But what's really interesting here is that we noted that when they did spirometry on post-op day 1, FEV1 was only 45% of predicted for their age, height, and weight. So the thing about it is this math that we say, well, oh yeah, you can do it if you leave 40%, that's based on our best guess of what it's going to be like. And normally you don't actually get to that best FEV1 until about 6 months after surgery. And here what we're seeing is that the worst case FEV1, which happens, say, on postoperative day 1, might be actually 30% lower than what you predicted it was going to be. And that's very significant when you're operating on a marginal patient, because you might think you've got them at 40%, but they might only be at 28% on post-op day 1. And we experienced thoracic surgeons know that on post-op day 1, if you're not coughing, if you get a sputum plug, that's when you get atelectasis, that's when you get a pneumonia, that's when you start to go down the drain, that's when you get intubated, and those are the patients that die. So this is a very important thing to consider. So if we look at even a little bit more in depth, this same group looked a little more closely at their patients. They said, let's look at different variables that predict outcome. And what they noted was that the most important thing was actually here, that first day FEV1, that how low the patient's FEV1 was on that postoperative first day was actually the single most important determinant of whether or not they were going to get morbidity or mortality from their thoracic surgery. Now, there's a few things that are interesting here. Patient age, sure. One thing that's interesting is the use or disuse of a video-assisted procedure was not particularly important. And I think a lot of that has to do with this paper was presented, about probably data that's about 15 years old. And also they talk even about it being video-assisted, and they don't necessarily specify the numbers of the patients. So I think this is probably, there were some mini thoracotomies or maybe some rib spreading going on, maybe not what we would consider a true thoracoscopic lobe. But I'll come to that a little bit. But what we do know is these disruptions in chest wall mechanics, pulmonary edema, pain, etc., are very important, and they happen on day 1. So anything you can do to potentially minimize your issues on day 1 are going to get your patients, especially your marginal ones, through the operation, and that's really what's key. So in a small study done in a Japanese center where we know they were doing kind of true thoracoscopic procedures, they just looked at VATS FEV1s versus thoracotomy FEV1s, just a small group, 10 patients in each arm basically, but they noticed that the difference happened early. And you can see here that on post-op day 7, there was quite a dramatic difference in the VATS FEV1s, which went down from, say, 100% of their preoperative value to 70 after a VATS procedure, whereas after a thoracotomy, they went down to about 55. And then as we talked about late phase at 6 months, yeah, they come back together. We know that as well from lots of data that your advantage in VATS probably goes away after 6 months versus thoracotomy. But it's in that first few days where it really matters, especially on marginal patients. And that's what I'm trying to show to you here. And further on, we're seeing a little bit more of this same type of thing. In this very provocatively named paper published by, I think this was a group at Dr. D'Amico's group in the US, they talked about how pulmonary function tests do not predict pulmonary complications after thoracoscopic lobectomy. And that's a very provocative title, but what you see here is in this top group here, in this top graph, we're looking at postoperative predicted FEV1s for patients that had thoracotomy and the percentage that had complications. So if you had a postoperative predicted FEV1 of 60%, low complication risk, but as your FEV1, postoperative predicted FEV1 got worse, your complication from thoracotomy dramatically got worse. So if you were expecting less than 30%, you had a really high complication rate. Whereas VATS is in white, and there's less or perhaps no correlation, which is what they're suggesting. And similarly with DLCO, you get what you would expect with thoracotomies. As the postoperative predictive DLCO goes lower, the complication rate goes higher, but with thoracoscopic procedures, it was not correlated. I'm not sure that that's true in all cases, but it's certainly interesting, and it certainly does reinforce the point that when you have a marginal patient, whatever you can do to minimize that chest wall disruption and keep them comfortable and make sure they're taking good breaths on day one is critical. And similarly here, this is a much bigger paper now. We're looking at a STS database, a set of 12 or 13,000 patients rather, and they looked at lobectomies that were done in the US, and so this is 2012, 8,500 open versus 4,500 VATS. And again, you can see that there were complications where 22% open versus 18% VATS, small difference, but here's where it's important. If your postoperative FEV1 was greater than 60%, then it didn't matter. That's these bars on the right. Whether you had a thoracotomy or a VATS, your complication rate was about the same. But here's where the dramatic change was. If you had an FEV1 less than 60%, that's where it really mattered whether you did the operation VATS. And that makes tremendous physiological sense to all of us. We know we'd love to do a VATS on everyone, but if you got a 40-year-old with great chest wall mechanics, they're not going to get as much benefit as an 80-year-old with emphysema. They're really the ones who are going to benefit from it. And I think that's what's borne out in a lot of this that I'm trying to show you here. So that's a little bit about the procedures that can be done. And again, just the critical nature of making sure patients are able to take good breaths and are comfortable on post-op day one. If you go around on the ward as a junior trainee on day one and the patient can't cough and bring up some sputum because they're in too much pain, that's an emergency. That needs to be dealt with on the ward round that morning, not by the time you come back in the afternoon. You need to make sure that that's dealt with right away, or that patient's going to fall down the hole and get into trouble. And I think all experienced thoracic surgeons would echo that. Now, I'm just going to shift a little bit to some of the anatomical variations. So one thing that we know is when we calculate the postoperative predicted FEV1, we all know this as trainees and senior surgeons, that we do this based on some math that the previous speaker talked about, the number of segments that we're going to remove. So we're doing a right upper lobe. So we'll say we're removing 3 out of 18 segments. We lose 1/6 of our lung function, and we do the math on that. But one thing that's interesting to note is, and we know this from, for example, for patients that have lung volume reduction surgery, sometimes removing segments actually helps people, in particularly if they have hyperinflation or COPD. And that's borne out here. I was in a conference once, and some old surgeon got up and said, look, a right upper lobectomy is a haircut. Anyone can have a right upper lobectomy. It's not hard for a patient to get through. And that old wisdom from that old surgeon is borne out in some of this information. And what we see here are patients that have had right upper lobes, left upper lobes, right lower lobes, and left lower lobectomies. And we look at patients here with COPD versus non-COPD. And what's really interesting is if you look at patients who have COPD and have had a right upper lobectomy, at 1 month, you can see that their FEV1s have improved marginally. They're basically the same at 1 month post-op in terms of FEV1 if they have COPD as they were preoperatively. Whereas at 6 months, they've actually got a little bit more benefit, say 4% plus or minus 20. So now we're talking about that lung volume reduction benefit, which makes sense. We know that lung volume reduction does help patients. And you see that most in the right upper lobe. You see it a little bit with the left upper lobe, where at 6 months, they're probably pretty close to baseline, but not as dramatic as an effect in right upper lobe. Whereas in lower lobes, you don't get that benefit. And that again makes sense, with the heterogeneity, or rather the homogeneity of disease, you're not gonna get that lung volume reduction benefit that often. But it's a good thing to keep in mind. So if you've got a marginal patient and they've got a tumor sitting in the right upper lobe, and it's mostly all bullous disease there anyway, you can say to your anesthetist, your anesthesiologist, your respiratory physician that, look, I know on the numbers they don't look great, but we actually, it's a very good chance we're going to make them better with a resection because we're going to get that lung volume reduction benefit, and that's borne out here. So that's most of what I wanted to talk about in terms of physiology and how we can get patients that are marginal through surgery. What I just want to talk about is, should we be getting patients through surgery? So just very briefly, I'll touch on that. This is a quality of life study that was presented. And what you see here on the right is a utility score. So the higher the utility score, so the closest to 1, the more patients think that this is important and I would totally do this and to get my lung cancer operation. So patients were asked the question about possible outcomes after lung surgery. And you can see if they had a pneumonia that was requiring 2 weeks of hospitalization, that wasn't so bad. If they needed to be on a ventilator for a week, that wasn't that bad, 0.75. A ventilator for a month, getting bad, 0.6. But permanent ventilator dependence with estimated survival of 6 months, nobody wants that. And what you can see here is if we compare things like having a heart attack because you had your surgery, that's 0.5. Having ventilator dependence for 30 days after lung surgery, that's 0.6. People will take that for lung cancer resection. However, what they won't tolerate is down on the bottom. This is what they don't want. They don't want to need assistance with their activities of daily living. So if you operate on them and you have no complications and they leave the hospital 2 days later, but they can't brush their teeth without being short of breath, they don't want that. If they can't get out of bed, they're limited to a bed to chair existence, they don't want that. If they've got progression of their lung cancer, so you actually haven't done a curative operation, then of course they don't want that. Or if they permanently have to be in a nursing home, whereas they were independent beforehand, that's not something they want either. So those are the real things that patients care about. And that's summarized this way. Basically, returning to function and being cancer-free are the patient's priorities over complications, as long as the complications don't have long-term sequelae. So you have an acute MI or you have a pneumonia that requires you to be intubated for a couple of weeks, but you're going to get over it, that's okay. But you have no complications and you're stuck and you can't do your activities without getting short of breath, that's something no patients want. So just quick summary. Basically, thoracoscopic operations now enables to push the boundaries of lung resection, and likely this is due to less interruption of the physiology in that early postoperative period where it really matters, where we know the patients run into trouble, day 1, day 2. The poorer the candidate, the more potential benefit of VATS over open. Now that presents a bit of a challenge to those who are new to the practice. You probably shouldn't be doing your first VATS lobectomy on an 80-year-old with a postoperative predicted FEV1 of 36%, because if you have to convert to thoracotomy, that patient's not going to do very well. They might not do well anyway. So as you become more experienced, you can push the boundaries because you know you're able to get patients through VATS, but that's something to consider. Also, anatomic and underlying structural features play a role in your assessment, and really we need to remember to ascertain patients' preferences. Anyway, that's it for my talk. I hope, happy to take some questions, and I hope that's helpful. Thank you.
Okay, thank you, Naveed. Dr. Naveed, for that great presentation. Yeah, I'd like to, those who want to have questions, please type in your questions at the Q&A. Yeah, I have one question to Dr. Padungkiat, or maybe Dr. Naveed can answer this too. So if because of the numerous variations that you've shown in your lecture, would you recommend doing a fissure first or a fissure last for, to prevent inadvertent injury to, variations in the PA anatomy when doing VATS?
I think fissure first or fissure last doesn't matter as long as you you mobilize the important structure enough. So if you do a right lobectomy after you cut a vein, if you mobilize it clearly, you can see the right middle lobe PA, you can see the posterior ascending, it coming off, and if you go far enough from the posterior ascending artery, you can see if there's no superior segmental PA. so you can safely cut the artery. Mm-hmm. Same thing to the other structure, but you need to make sure that you mobilize it enough. You remove the lymph node, because if you remove all the lymph node around there, you see all the structure.
So you prefer nodes first after the lobectomy?
I normally do a fissure last technique because the alley postoperatively is very low.
Do you also use the grade fissure, whether it's a grade, a grade 1 or 2 fissure?
Excuse me, can you repeat your questions again? The signal's lost.
Oh, I'm sorry. Yeah. Do you follow the grading of the fissure, whether you have a thick fissure or a thin fissure, for you to do a fissure first or fissure last?
Right. So if the fissure is grade 1 or 0, I would just do, it doesn't matter. I think you can go through the fissure and you can see any structure, and there's no problem. But if the fissure is very thick and you can't go through with a couple spreading, normally I'll do just quick small blunt dissection. If you blunt and there's a plane between the visceral pleura and it's slowly open, I might continue to open that. But if it looks like it's not going to work through the fissure, just do a fissure last technique.
Dr. Naveed, there's a question here with regards ascertaining the patient preference. Can you clarify this patient preference that you mentioned earlier?
Sure, thank you. This is a quality of life study, and patients were given a scenario where you're going to have lung cancer surgery. If your outcome is this, that, or that, how would you react to that? And what it showed was that patients don't mind complications as long as after the complication happens, they get back to return of function. So if they need to be intubated for 2 weeks following a lobectomy because they have a pneumonia, they don't mind that as much as if they have an operation which goes smoothly, but their pulmonary physiology afterwards is not good enough for them to get home and they have to go to a nursing home. So really what I'm trying to show is it's critical that it's not just about getting the patient cancer-free. You got to get them cancer-free, and they have to have returned to normal function, at least what's normal for them. Because if you have a dramatic decrease in that, then they don't want any part of it. They'd rather just not have the operation to begin with.
Okay. There's another question here for you. What is your opinion on preoperative low-cost exercise testing in preoperative physiologic assessment, like the shuttle walk, stair climbing, six-minute walk test, as compared to like doing your routine pulmonary function testing?
So we're probably quite fortunate here in Australia that we don't have to worry that much about the costs of some of these preoperative tests because they're sort of provided by the government. But certainly in other jurisdictions, other medical systems, I can see that's very important. And I think that if someone is, from the foot of the bed or when they're in your office, that they don't have any complaints, they're otherwise pretty well, and you can do a 6-minute walk and they can get, 500 meters or 450 meters, then that's okay. Really, I think you can be guided a lot by that, but it's on the marginal patients that it's probably still worth doing the more aggressive and thorough assessments. For example, we actually did, we've done in the past few months, what for us is unusual, doing some lung resections without any pulmonary function tests because of the COVID situation. The respiratory labs were harder to get patients into. They didn't want to do testing, and we still had some cancers to operate on. And we were doing that. We were doing 6-minute walks, and we said, look, if you can get 450 meters in a 6-minute walk, then that's fine. You can have a lobectomy. So there is data out there to support that kind of stuff. And same like stair climbing and pulse oximetry. I think those are all quite reasonable.
So with regards to values you mentioned about the pulmonary function, like the LCO more than 80%. Does that also apply for if you do a lobectomy plus a chest wall resection? It's one of the questions.
Yeah, so that's an excellent question. I think in chest wall resections, more than any other thoracic surgery, you need to be really aware of the mechanics. So I think it's definitely going to factor it in. If you're leaving people with FEV1s and DLCOs of less than 40% on both measures and you're doing a chest wall resection, then you're going to be a little bit more concerned. You're going to be, the marginal gain is tougher. So that's a judgment call. You need to make sure that your prosthesis in your chest wall resection then is good. So you're trying to maintain chest wall dynamics as best you can. And you need to make sure your analgesia is as good as possible, because it's still a function of how well they're going to do day one, day two. You know, if you do a big chest wall resection and you've got good analgesia on board, be it a paravertebral catheter or an epidural, and you've stabilized the chest wall, then you could probably get away with the similar stuff that you would have otherwise. But you got to be really careful and really aware of it. And we have a very low threshold, for example, on anyone who's had a chest wall resection. I would have a very low threshold to do a bronchoscopy on them on day one. If they're not getting their secretions out because they're splinting, they're in enough pain, straight to the bronch suite and help them suck things out. So I think that's a reasonable thing to do. You also probably want to put them on humidified oxygen immediately post-operatively so their secretions are moister. Anyone that we've done a sleeve on or a chest wall resection, we'll put them on that just to keep the secretions a little moister, make it easier for them to expectorate. I think those are the important things.
Yeah, there's a question here. In other countries, still not doing a lot of VATS. They're doing instead lateral thoracotomies, muscle sparing, and doing adjunctive analgesic maneuvers like intercostal blocks. Would you equate that with similar outcomes with doing VATS right now?
So I think it's really hard for me to comment on that. I've seen some amazing things like there's this Brazilian surgeon that does, I don't know if anyone's seen this guy on YouTube. He does these thoracotomies with all these adjunctive analgesia, and he has patients coming out of the operating room 4 hours post-operatively, like doing push-ups and things like that. So I think it depends on your system. And probably you have to be guided a little bit by the experience that you have in your unit with that. It's hard to extrapolate the data. We just don't have that data. But you can see, I think the main thing is, and I think the experienced surgeons would agree that if your patient on post-op day one can take a deep breath in and cough, then they're probably going to be okay. And they should be able to get rid of their secretions and do that. It's because you need to get them over that post-operative period where that's the big problem.
Yeah, a question for Dr. Padungkiat. Would you recommend doing routine 3D reconstruction of CAT scan images, or would you just recommend it for certain or particular cases that you do?
Standard lobectomy without sleeve or without the chest wall resection, I normally don't do any 3D reconstruction because I think you look through the CT scan yourself, it's always better.
Can I just make a little comment on that, Ed?
Yes, maybe.
I think that, and I agree, I don't routinely do it at all, but I think that if you're new to VATS, you're just starting your first couple of cases, and you're doing, say, a left upper lobe, where we know that the pulmonary arterial anatomy is the most variable. You could have, 2 to 7 branches. It might be, in some of that situations, there might be some value in doing something with a little more cuts, a little finer, even if it's a CTPA, perhaps, just so you can get and you can do, the reconstructions are easy, but just so you can get a bit of an idea of the map before you go ahead. I would think that's not unreasonable if you're just starting out and you're doing something like that. But certainly routinely, I wouldn't advise it.
Yeah, agree.
With regards to the guidelines you mentioned, the flow charts, the ACCP and BTS guidelines are based on lung cancer surgery. Now, in a lot of the countries in Southeast Asia, we do encounter a lot of inflammatory conditions with like an entire lobe which is contracted for aspergillomas or bronchiectasis, or maybe you're doing pneumonectomy for a completely destroyed lung. Does this guideline apply, the volumes, the cutoffs?
No, I don't think they do, but I think in those settings, what you need to do, possibly, like if you're thinking of doing, if you're having to do a pneumonectomy, then I think you probably want to add that next layer of something like a ventilation perfusion scan, quantitative VQ scan, so you do understand, so you're not just doing the simple arithmetic of how many segments you're losing, because those segments aren't functional anyway. And there might already be shunting or dead space ventilation happening there. So in that setting, I think you'd probably be guided a little bit more by that.
Yeah, there's an add-on question to that, to Dr. Padungkiat. If you're doing inflammatory conditions and the anatomy is all messed up, what do you recommend preoperatively to try to minimize any vascular misadventures?
So I think the anatomy is anatomy, even though there is a post-radiation inflammatory that can cause a scar around the important structure. But if you stick to the ground, that you review your CT scan carefully, and when you go in there, go with your mapping in your head, I think you should be okay. But adding the 3D reconstruction, it would help. I think it would more beneficial if you want to do a segmentectomy. That would help you. But if you just want to do a lobectomy, you just make sure that there is no variation that your lobes are rising from the other lobes. You should be okay. Just to make sure you go slow, and doesn't cause a problem.
Okay, so we have more questions, but in the interest of time, we'll have to end the Q&A. So if you have any questions, maybe you can email our presenters directly, and maybe they can answer your questions. So, well, I'd like to thank our two presenters for that excellent presentation. So we learned a lot. This presentation will be eventually posted on the SEATS website for others to review and rewatch. So any last comments from Dr. Padungkiat and Dr. Naveed?
I might just add one little thing that I really appreciate what Hong was saying about fissureless versus fissure. It doesn't matter that much, because once you take the lymph nodes out, you've got all the pulmonary artery displayed. So whether you go through the fissure or do the fissure last, you should know what you're dealing with. The one thing I will just add on is, let's say worst case scenario, you do take out the posterior ascending artery to the right upper lobe when you were trying to do a right lower lobectomy. I don't think you necessarily have to then remove the right upper lobe pulmonary posterior segment. We know that if you maintain a venous drainage of the lung, of the lobe, then it's going to be viable, because it's still going to get some arterial supply from the systemic side, as well as from the other segments. Whereas if you are doing if you took out the venous drainage, say of the middle lobe, then yeah, by mistake, like you thought you were sailing through the upper lobe vein and you divided the middle lobe vein completely, then yeah, you'd have to take the middle lobe. But you can probably get away with leaving a segment behind, even if you've lost the pulmonary arterial side to that.
Yes, I agree with you. This is a very important point that the audience has to understand, that there's the artery has two circulation. It's not just a PA, but vein is the more important. We just had a local inter-hospital case conference like this, and the operator inadvertently removed the big interlobar vein on the right superior pulmonary artery, and ended up had a had a pulmonary infarction of the part of the right middle lobe. 3 days after, you go back in and remove the right middle lobe. Right. Thank you.
Okay, so well, again, thank you for two speakers for that wonderful presentation. So next week, we're going to have a similar webinar. We'll be posting the schedule online and on the SEAT's website. Again, thank you very much, Dr. Padungkiat and Dr. Naveed for that presentation. Thank you very much for everyone for attending this webinar.